Good morning, everybody. Today, my next lecture devoted again to hemorrhage condition in obstetrics during labor and postpartum period. Also, it is connected with uh, DIC syndrome and, of course, with hemorrhagic shock. And we'll touch problems of amniotic fluid embolism and, of course, intensive care in obstetrics because of all these uh, emergency situations. I'm Dr. Lifshitz, Associate Professor of the Chair of Obstetrics, Gynecology and Perinatology, #1. I want to start from the epigraph from Williams Obstetrics, the well-known textbook, that obstetrics is a bloody business, said one of the authors, Dr. Jack Pitchard, in 1976, and it is really so. Obstetrical hemorrhage continues to be one of the three possible causes of maternal deaths in obstetrics, along with hypertension and infections. Hemorrhage was a direct cause of nearly 13% of 4,693 pregnancy-related maternal deaths in the United States, and as well in developing countries. And its contribution is even more striking there. Previously, we discussed antepartum hemorrhage and we touched abruptio placentas, but I would like to repeat some of these issues also related with the process of delivery. Abruptio placenta, or separation of the placenta, premature separation of placenta, usually normally implanted. It may happen before labor and during labor, of course. Abruptio placenta may be partial and may be total. And this is the most common cause of third trimester bleeding and bleeding during labor. Etiology of abruptio placenta related to several causes: obstetrical, to concurrent disease, and maybe some other things like hard work, mechanical traumas, stresses. For us, everything is also of importance, and especially obstetrical causes like preeclampsia, eclampsia, gestational diabetes, absolutely shortened umbilical cord, and of course concurrent diseases which are very common now in the modern world among pregnants and during the delivery process, maybe pyelonephritis, concomitant heart disease, diabetes mellitus, septic conditions, and vascular diseases, as well as avitaminosis. The precise mechanism underlying this form of hemorrhage is not very well known, maybe unknown, but commonly the hemorrhage occurs from peripheral placental blood vessels without evidence of intrinsic vasculopathy. This process causes vaginal bleeding without retroplacental clot formation, disruption of intravillous blood flow, maternal coagulopathy, or negative hemodynamic effects. When the bleeding is confined to a relatively small portion of the periphery of the placenta, the patient is the most often stable, as the remainder of the placental surface continues to perform the functions of nutrient exchange sufficiently. Clinical pictures of premature separation of placenta is characterized by several symptoms like sudden, usually strong abdominal pain, vaginal bleeding, uterine consistency becomes firm. You can notice alteration of the uterine shape and uterine size, alteration of the fetal condition, intrauterine fetal condition, of course. The membranes, amniotic membranes, are very tense both during the contractions and between the contractions. And of course, symptoms and signs depend on the degree of separation of the abruption and the blood loss. How can you put a diagnosis? Of course, clinical signs are very important. All that I mentioned before is very important, starting from pain till shape of the uterus and well-being of the fetus. Ultrasound investigation is of help. You can notice the hematoma formation during the ultrasound. Vaginal examination is performed only if the placenta previa is ruled out by ultrasound study. CTG is very helpful for evaluating the fetal condition. What's the management of abruption of placenta? If bleeding is light or moderate, it depends on the fetal heart rate, what you need to do. If the fetal heart rate is normal or absent, first, if uterine contractions are poor, you can augment labor with oxytocin. The second option, if the cervix is unfavorable, so Bishop score less than 5, you need to perform immediate cesarean section. The second situation, if the fetal heart rate is abnormal, you can hear the fetal heartbeats, but it's less than 100 per minute or more than 180 per minute. So in this situation, which is indicated for fetal suffering, you need to perform vaginal birth, delivery to be done during 1 hour, not longer. Or if vaginal birth is not possible, delivery is not possible, please perform immediate cesarean section. Also, you need to remember that forceps delivery may be advocated in cases with head engaged to the pelvic floor if the fetus is alive. In cases if fetus is dead and full open cervix, a destructive operation on the fetus may be performed, but very rarely nowadays. What to do in case of heavy bleeding, massive hemorrhage? Abruption of placenta can be associated with hypovolemic shock because the blood goes to the uterine cavity or invades the myometrium. Failure to institute prompt fluid or blood component therapy or both may contribute to risk of maternal death, acute tubular necrosis, shock liver, or adult respiratory distress syndrome. Treat the bleeding and fetal distress with delivery. So often we proceed for cesarean section, and you need to treat blood loss and to prevent and treat DIC with IV fluids, blood products, and we'll touch DIC later with some heparin drugs. Patients should be referred to the hospital if abruption of placenta took place during the labor outside of the hospital. So please, you need to hospitalize the patient. Large bore intravenous catheter should be placed, and you need to send for laboratory investigations like CBC, fibrinogen level, coagulogram, electrolytes, creatinine level, cross match for blood type. You need to be prepared for massive blood transfusion. And of course, you need to control urine output by inserting the catheter into the bladder. Uteroplacental apoplexy, which is well known by the name as cuvulary uterus, it is on the picture, on the photograph, may be developed if the patient has pre-existing preeclampsia, and unfortunately those patients usually requires hysterectomy to be done because this uterus is not contracted very well because of this apoplexy. The separated placenta is delivered immediately after the fetus. Large amounts of blood, liquid blood and clots are discharged together with the placenta. The overdistended uterus shrinks slowly, and the bleeding therefore often continues during the first hours postpartum due to uterine atony and unfortunately coagulopathy and probably DIC syndrome. So please remember it. The next problem which may lead to obstetrical hemorrhage is uterine rupture of the uterus. The incidence is very low, 1 of 10,000, 1 to 20,000 deliveries in scarred uterus patients. It may happen during so-called neglected labors. This accounts for many maternal deaths where modern obstetric care is not available, unfortunately, maybe in your countries, in developing countries. So please keep in mind this. What are the risk factors for uterine rupture? These are obstructed labor, cephalopelvic disproportion, anatomical narrow pelvis, prior uterine surgery, myomectomy for uterine leiomyoma, problems when or surgeries for treating abnormalities, uterine abnormalities, and of course cesarean sections which were previously done for specific patient. Uncontrolled use of oxytocic agents and uncontrolled use of prostaglandins, which are nowadays used very widely in obstetrical practice. The diagnosis of uterine rupture need to be done fast, quickly. How come? By clinical symptoms, overt or internal hemorrhage, pain, sharp pain usually in a specific place of the uterus, shock conditions, creating of the pelvic hematoma, hematuria, because when the bladder is involved to the rupture, bleeding tends to be heavy when the cervix and upper vaginal wall are involved. Please do ultrasonography, complete blood count, and of course coagulogram for understanding the severity of hemorrhage syndrome. So what you need to do? Please restore blood volume quickly as soon as possible by infusing IV fluids, normal saline or rigorous lactate preferably, even before the surgery. When stable, you need to perform a laparotomy to facilitate the birth of a baby and delivery of the placenta. When you're doing surgery, please try to keep the uterus in place for the future fertility reasons, and because the hysterectomy is more aggressive, more massive surgery, associated with more blood loss, more difficult surgery. So it's better to put stitches on the wound of the uterus and try to keep the uterus inside. The postpartum hemorrhage is another condition which is by name usually starts after the delivery of a baby. Obstetric delivery is associated with acute massive blood loss. Worldwide, more than 125,000 women die annually from primary postpartum hemorrhage, and this diagnosis remains one of the top 5 causes of maternal mortality, both in developed and in developing countries, everywhere across the world. The classic definition of postpartum hemorrhage is bleeding in excess of more than 500 milliliters following the 3rd stage of labor, while severe PPH is defined as blood loss of more than 1 liter within the same time frame. Although when blood loss has been accurately measured and uncomplicated vaginal deliveries, it has averaged about 600-650 milliliters, while at uncomplicated cesarean sections, it is up to 1 liter. The normal intravascular volume expansion during pregnancy allows loss for 1.5 liters blood at delivery without any significant hemodynamic effect. PPH is classified as primary or early if it occurs within the first day, 24 hours of delivery, and a secondary or late if it occurs more than 24 hours after delivery, until the 6 weeks postpartum. The woman with preeclampsia, however, does not undergo the normal volume expansion and may poorly tolerate even a normal blood loss at delivery, which may have profound shock with physiological blood loss well tolerated without the preeclampsia. The usual etiological factors are, first, retained products inside the uterus, uterine atony, the most common cause of postpartum hemorrhage, low genital tract trauma, uterine rupture, we touched it before, uterine inversion, and coagulopathy. This is the graph which shows the mortality rate from hemorrhage, postpartum hemorrhage, due to different most common causes. And you see the atony of the uterus, atony of the muscle of the uterus, take probably the first place, giving up to 18% of maternal mortality. And DIC also have big part in it. Abruption of placenta, laceration of the uterus and genital tracts. And you see the retained part of placenta usually has the smallest numbers of maternal mortality rate. What are the risk factors of postpartum hemorrhage due to uterine atony? First, uterine overdistension due to polyhydramnios, because of multiple gestation, twins, triplets, and so on, microsomic fetus. This all may cause uterine overdistension. Grand multiparity, so rapid or prolonged labor. Next, uterine relaxing agents, which are used widely because of the risk of premature labor. Magnesium sulfate, nifedipine, beta-mimetics, indomethacin, nitric oxide donors. Also, the use of oxytocic agents for labor induction, like oxytocin itself or prostaglandins, may also cause uterine atony. Chorioamnionitis during labor is the next cause of uterine atony. Some of the anesthetics, and don't forget gynecological pathology like leiomyoma uteri. All those factors are risk factors of postpartum hemorrhage due to uterine atony. For retained products of placenta, are retained membranes, placenta accreta, placenta increta, and placenta percreta, which are different pathology, but this is the risk factor for retained products. And of course, retains small part of the placenta, like lobe. The risk factor for the trauma and PPH after the low genital trauma is episiotomy, usually 4th degree episiotomy or perineotomy, forceps or vacuum delivery, vaginal wall or cervical wall lacerations. Trauma also may be due to fetal microsomia and because of the precipitant, very quick delivery. The next problem is uterine inversion. On the picture you see completely inverted uterus with attached placenta and umbilical cord. This lady unfortunately died of their postpartum hemorrhage due to uterine inversion. Risk factor for the uterine inversion is using magnesium sulfate, which may relax the uterus and prevent premature labor. And the next very important risk factors is excessive traction of the umbilical cord on the umbilical cord during the third stage of the labor. Uncontrolled traction of the umbilical cord. So please keep your hands usually off the umbilical cord unless you're practicing active management of labor. What to do with the inverted uterus patients? First, you need to understand that this is a very painful situation. Patient may feel shock, pain shock. You need to give painkillers like morphine and try to reposition the uterus to correct the inversion. And you need not to give the uterotonic drugs until the inversion is corrected. So you need to give painkillers, ask the anesthesiologist to help you, and also you need to ask for help for extra hands. Then you need to reposition the uterus. This is the operative maneuver, like it's shown on the picture. And only after you reposition the uterus normal situation, you may give uterotonics only after it. The risk factor for the coagulopathy, PPH, is amniotic fluid embolism, and we will touch it later on. Pregnancy-induced hypertension and preeclampsia, abruptio placenta and placenta previa, sepsis or septic shock, retained dead fetus inside the uterus, and inherited coagulopathy situations. In medicine and in obstetrics, you need to have the feeling of the anticipation of everything, and especially for postpartum hemorrhage. The clinician should ensure that a specific patient with some risk factors has adequate intravenous access, intravenous line, and all the obstetric team need to anticipate and be prepared to deal with obstetrical hemorrhage. It's very important to have this feeling, the anticipation, to prevent and to treat in case their condition takes place. So all gravidas should have blood type, rhesus factor, antibody screen performed as a routine part of prenatal care. So you need to know for every pregnant woman her blood type, rhesus type, and antibody screen, because obstetrics is a bloody business. In women with identified risk factors, large bore intravenous catheter should be used, and hydration should be maintained, and uterotonic agents should be readily available in the delivery ward. The first steps in management are: you need to stabilize the women's vital signs and stop the hemorrhage. So please, you need first to stabilize the condition of the woman, and then you need to, in parallel, you need to stop the hemorrhage, the source of hemorrhage, which is usually atonic uterus, as I mentioned before, or maybe lacerated genital organs, or maybe retained products inside the uterus, and so on, and maybe because of the coagulopathy. Also, you need to work as a team. Not only you are a doctor and you are the only one. It's not a one-man show. You need to work as a team with your nurses, midwives, and other doctors, by the way, other specialists like anesthesiologists and maybe a neonatologist altogether. It's very important. Initial fluid resuscitation can be performed with crystalloid solutions, given at the ratio of 3 milliliter crystalloids for each milliliter of the estimated blood loss. For example, if an estimated blood loss is 1.5 liters, the woman would be resuscitated with 4.5 liters of crystalloid solution. So 1 to 3, 1 milliliter of the blood loss, you need 3 milliliters of crystalloid solutions. When acute blood loss approaches to 2 liters, red blood cell transfusion will almost always be necessary. So crystalloid solution is not enough in case of massive hemorrhage, massive postpartum hemorrhage. This is especially so if the hemorrhage has not been stopped and blood loss is ongoing, as well as in the woman with preeclampsia, because they tolerate the blood loss worse than pregnancy or than woman without the preeclampsia. Please don't forget about Foley catheter. You need to control their urine output, the work of the kidneys. So in case of oliguria, which is defined as less than 30 milliliters in an hour or less, it is an excellent indicator of hypovolemia and the need for future expand the intravascular compartment. Assessment of the uterine tone is always the next step in the management of primary postpartum hemorrhage, because uterine atony is their dominant cause of primary PPH. If the uterus is atonic, immediate attention is given to mechanical massage and pharmacological maneuvers. Bimanual uterine massage, in conjunction with evacuation of clot from the uterine cavity for retained products of conception, intrauterine or intracervical lacerations. On the picture, you see the technique of the massage, uterine compression, by manual uterine compression. You see your active hand. All your hands should be. You need to be wearing gloves, surgical sterile gloves. Then you insert your active hand in a vagina, in the anterior wall, and compress with your other hands from the above the pubis, and to do compression of the uterus between your fingers, between your hands. Wearing sterile glass is very important, and you need to maintain compression until bleeding is all controlled, at least controlled or stopped. The next option is to do an external aortic compression. This is the technique. You need to apply downward pressure with a closed fist over the abdominal aorta directly through the abdominal wall. The point of compression is just above the umbilicus and slightly to the left, because the aorta goes slightly to the left of the vertebra. Aortic pulsations can be felt easily through the anterior abdominal wall in the immediate postpartum period. With the other hand, palpate the femoral pulse to check the adequacy of compression. If the pulse is palpable during compression, the pressure exerted by the fist is inadequate. If the femoral pulse is not palpable, the pressure considered to be exerted as adequate. Maintain compression until bleeding is controlled, or alternative measures can be taken. On the picture you see the schematic of this maneuver. You need to press with your finger, with your fist, and control the bleeding by doing this maneuver. Some pharmacological preparations can be used as well for atony of the uterus, which are oxytocin, which is available in every maternity hospital for augmenting the labor, for contractions, and for postpartum hemorrhage as well. So please use 10 international units of oxytocin intramuscularly, or even intramyometrically. Also, you can dilute intravenously those 10 units of oxytocin in 1 liter of normal saline. This is usually the first line of treatment, to give the oxytocin. The next the next agent is methylargonovine, which usually prescribed at 0.2 milligram intramuscularly, but is contraindicated in women with preeclampsia or poorly controlled hypertension, because it may induce hypertension. Methylprostaglandins F2 may be given as a dosage of 0.25 milligram intramuscularly or intramyometrium. The next agent is a misoprostol, which is prescribed orally or rectally, 800 microgram or even 1000 microgram. Tranexamic acid can be injected slowly intravenously, usually 1000 milligrams. You can repeat this preparation after 30 minutes if bleeding is continuous. No more than 10 milligram per kilogram body weight, please. Usually is indicated 3 or 4 times daily. But tranexamic acid is contraindicated in history of coagulopathy or active intravasal clotting, and in case of convulsions or fits. The next option is to do intrauterine balloon tamponade. It's one of the new options which now used across different maternity hospitals. This is the special catheter, which is looked like this. Balloon is inserted into the vagina, and then you put in the uterine cavity, and you can inflate it. And it compresses the placental bed, which and internal walls of the uterus, which may bleed, and control the uterine atony. After 6, even 24 hours, if the uterus fundus remains at the same level and there is no active vaginal bleeding, you can deflate the balloon, 50 milliliters usually every hour. And if no further bleeding, you notice, you can deflate it completely. Coagulopathy is both a cause and a result of massive obstetrical hemorrhage. Please remember it. Coagulopathy is a cause and maybe a result of the hemorrhage. It can be triggered by a rupture of placenta, intrauterine fetal death, eclamptic patients, amniotic fluid embolism, and many other obstetrical causes. The clinical picture ranged from major hemorrhage with or without thrombotic complications to a clinically stable state that can be detected only by laboratory testing. Coagulopathy is clinically suspected on the basis of diffuse oozing, bleeding throughout the surgical field, as well as from peripheral sites such as venipunctures, Foley catheters, nasogastric tubes. So patient may bleed from every site. When you do injection, intramuscular injection, and it may bleed. If you put stitch, the place when your needle goes may ooze. You need to assess clotting status using a bedside clotting test. I described it on my previous lecture. Fresh frozen plasma, usually 15 milliliters per kilogram of the body weight, or cryoprecipitate may also be given on the clinical suspicion of the coagulopathy, and if your laboratory proves your suspicion, you need to give this preparation, fresh frozen plasma. So what to do next? If the uterus is firmly contracted, the next step is management to rapidly inspect the perineum, vagina, and the cervix for laceration which may bleed. If no lacerations are observed and supracervical bleeding continues, especially in the setting of the well-contracted uterus, then careful bimanual examination and manual uterine exploration should be repeated. Attention should be given to the contour of the uterine cavity, particularly along with the previous uterine scars. In case of suspected uterine rupture, exploratory laparotomy may be required in order to diagnose the uterine rupture, as palpation frequently fails to identify the defect. So you cannot miss their laceration, miss their rupture of the uterine in case of such bleeding. In patients in whom medical therapy fails, you need to disrupt the blood supply from the uterus and save the life of the patient. One of the modern methods of controlling bleeding is to put a so-called B-Lynch compression sutures. B-Lynch compression sutures. You see, you need to put your stitch over the uterus and to compress it. Compress it. With some time, usually several months, these sutures, the suture materials will be dissolved. Vascular catheterization and selective embolization of the uterine arteries may be one of the options to control postpartum hemorrhage, but unfortunately this method is not very widely used now because not many maternity wards and maternity houses are equipped with such sophisticated machines. Transfusion with packed red blood cells is often a necessary life-saving maneuver. 1 unit of packed cells will replace approximately 500 milliliters of the whole blood and should raise the hematocrit by 3% and hemoglobin by 10 grams on liters. Platelets are generally recommended to maintain a count greater than 50,000 cells per microliter in patients in whom surgery has been performed or when surgery is anticipated. Tears of the birth canal are the second most common cause of PPH. Tears may coexist with atonic uterus. Postpartum bleeding with the contracted uterus is usually due to a cervical or vaginal tear. Please examine the woman carefully and repair tears of the cervix. And don't forget, you can also use the tranexamic acid, which may stop or diminish the bleeding from the site on the cervix. Retained placenta can be found in case of postpartum hemorrhage. Sometimes a full bladder will hinder delivery of the placenta. So please ensure that the bladder is empty. If bladder is not empty, a patient cannot pee herself. You need to catheterize the bladder. Ensure that uterotonic drug has been given as a part of active management of the third stage of labor, and you may apply controlled cord traction, controlled to remove the placenta from the uterus. Avoid forceful cord traction, which may cause uterine inversion or cord rupture. If the placenta is not expelled, the afterbirth is not expelled. Give an additional 10 units of oxytocin in combination with controlled cord traction. If the placenta is not expelled and the woman is bleeding, attempt manual removal of the placenta. but not very adherent tissue may be placenta accreta. Efforts to extract a placenta that does not separate easily may result in heavy bleeding of the uterine perforation, and these may lead you to proceed for laparotomy and to perform a hysterectomy, because placenta percreta cannot be detached by manual examination. Check placenta for completeness always in every single delivery. After delivery of placenta, you need to control their integrity of placenta. If there are signs of retained placental fragments, for example, you notice the absence of a portion of maternal surface or torn membranes with vessels, please remove remaining placental tissue because it prevents the uterus from contracting ineffectively. When an incomplete placenta is suspected, feel inside the uterus for placental fragments. Manual exploration of the uterus is similar to the technique described for removal of the retained placenta. Also administer a single dose of antibiotics, for example, ampicillin or the first generation cephalosporin, if the uterus is explored. On the picture you see how can we manage with the retained placental part or the whole placenta inside the uterus, and also the so-called massage on the fist is shown on the left picture. Secondary postpartum hemorrhage is defined as increased vaginal bleeding between 24 hours and 6 weeks after childbirth. Secondary PPH may be due to postpartum endometritis or retained products of conception inside the uterus. You need to give uterotonic drugs. If the cervix is dilated, explore by hand and remove large clots and placental fragments, so-called manual exploration of the uterus. Rarely, if bleeding continues, it may be necessary to consider surgical intervention with uterine or uterine ovarian artery ligation or even, unfortunately, hysterectomy. Always perform histopathologic examination of curetting or hysterectomy specimen, if possible, to rule out the trophoblastic disease. Women who have suffered PPH may require careful follow-up and special education about self-care and risk of infection. Women who experience PPH will likely require support from family members. Clearly explain the events and the treatments that occurred so they are understood by the patient and her doulas. Educate women on the signs and symptoms of intrauterine infection and encourage them to return to the hospital with any fever, persistent pelvic pain, and when her discharge, vaginal discharge, have foul smelling. Emphasize the importance of the good nutrition after PPH, including iron supplements, all measures for improving her general health, and facilitate milk production and breastfeeding, of course. Contraception is of importance. Very correct thought that estimated blood loss like a beauty. All is in the eye of the beholder. So the problem we as doctors try to evaluate estimated blood loss is always subjective. But it's very important to understand the blood loss, the volume of the blood is lost, because condition of the patient will depend on their class of the acute hemorrhage. On this table you see we have 4 classes of the blood loss of the hemorrhage. Usually it's percentage of the volume inside of the woman. And clinical measurements of pulse rate, pulse pressure, and blood pressure all depends on the volume of the blood is lost. Very important to understand what you need to do in case of massive hemorrhage, how to replace the blood lost. If the hemorrhage is less than 1 liter, you may need to give crystalloids only, not necessary to give more preparations and other blood products. At least 200% of blood loss volume need to be replaced by crystalloids in case of minor hemorrhage, less than 1 liter. In case of hemorrhage 1 liter to 1.5 liters, again, crystalloids are unnecessary. And plus, you need to give some colloids, around 1 liter of colloids. Also, plasma, fresh frozen plasma is necessary. And you need to know hemoglobin level and erythrocyte level during the CBC testing. And it's necessary to give blood transfusion in case of massive hemorrhage more than 1.5 liters. And cryoprecipitate usually need to be done 1 dose per 10 kilogram if fibrinogen less than 1 gram on liter. The principle of management of massive hemorrhage with signs of clinical shock, hemorrhagic shock, you need to have more extra hand. Call experienced midwife and alert consultant. Call anesthetic alert consultant. Call hematologist who is on call. Alert blood transfusion laboratory. And designate 1 member of the team to record events. It's very important to keep medical recording during this acute event of blood loss. And of course, utilize ABCD pathway. A stands for airway, B for breathing, and C, circulation of the blood, and D, assess the fetus and decide the type and the term of delivery. Transfuse blood as soon as possible. Until blood is available, infuse up to 3.5 liters of warm crystalloids, Hartmann solution, or ringer lactate solution, and colloid 1 to 2 liters as rapidly as required. Fluid therapy and blood product transfusion are so crystalloids up to 2 liters of Hartmann solution, colloid again 1 to 2 liters until the blood arrives. You need, of course, to blood cross match. Consider the use of red cell salvage if available, auto transfusion, auto hemotransfusion, fresh frozen plasma, usually 4 units of this plasma is given for every 6 units of red cells. If prothrombin time or activated partial thromboplastin time are greater than 1.2 of the mean control. Platelets concentrates need to be given if platelet count less than 50, and cryoprecipitate if fibrinogen level less than 1 gram on liter. And now you will have 5-minute break and we will continue. Okay, students, we'll continue the lecture. And the next topic is amniotic fluid embolism. This condition has come to be recognized as a dramatic and dire event responsible for more than 10% of maternal deaths in the United States. It is seen in terms of near-term patient, more frequently in multiparous. As many as half of patients will die during the initial resuscitative effort. Fetal mortality is also high. 50% of deaths occur in uterus. Strong uterine contractions, hydramnios, large uterus, high incidence of operative delivery, intrauterine fetal death, multiparity, meconium in amniotic fluid, and history of allergies. All those are predisposing factors for amniotic fluid embolism. The pathophysiology of this condition has not been entirely clarified until now. Rapid infusion of amniotic fluid with particulate matter, often meconium, into the maternal circulation lead initially to an immediate and sharp increase in mean pulmonary artery pressure, pulmonary vascular resistance, and resultant systemic hypoxia resulting from disordered ventilation and perfusion. This is followed by a second phase of left ventricular failure, severe reduction in left ventricular systolic work index, and secondary increase in pulmonary wedge and diastolic pressures. Thromboplastin-rich amniotic fluid triggers the intrinsic clotting system with rapid defibrillation and hemorrhage, thus aggravating an already complex cardiovascular picture. The amniotic fluid embolism syndrome is very similar to anaphylaxis and septic shock, and conditions also triggered by foreign toxins that enter the intravascular space. The sudden onset of agitation of the patient, dyspnea, anxiety, and respiratory arrest develops during labor, delivery, or in the first few hours postpartumly. In those who survive the acute event, left ventricular failure may develop in a clinical picture consistent with the adult respiratory distress syndrome, as well as disseminated intravascular coagulation. The differential diagnoses are acute pulmonary edema, pulmonary embolism from peripheral venous circulation, and cardiac arrhythmias. During resuscitative efforts, it is advisable to obtain blood from the pulmonary artery via central lines to look for fetal squamous cells, so-called Atwood stain, and mucin, Giemsa stain. Laboratory studies are shown on this picture. They usually require blood gas analysis, CBC with platelets, prothrombin time, coagulogram, of course, blood type and screen in anticipation of the requirement for the transfusion, and other imaging techniques is necessary to perform, like chest X-ray examination, CT scan, to rule out complications, other complications. The management should be following institute endotracheal intubation with maintenance of the oxygen flow. Cardiac resuscitative measures may be needed. Crystalloid should be administered to maintain intravascular volume and cardiac output. Careful attention should be paid to blood loss following delivery and measurement of clotting factors like partial thromboplastin time, platelets, fibrin split products, and fibrinogen. In the presence of disseminated intravascular clotting, Accompanying therapy should be initiated with fresh frozen plasma or platelets or both. Fresh frozen plasma, I will remind you, contains approximately 1 gram of fibrinogen in unit. Each unit of the platelets raises the platelet count by approximately 8,000 on microliter. Consult the intensive care service in anticipation to transfer to that unit. Please consult neurologist as needed if a patient shows signs of neurologic deficit. Drugs are used in amniotic fluid embolism to stabilize the patient. Are following: vasopressors, inotropes, steroids, uterotonics. Vasopressors, inotropes, steroids, and uterotonics. Patients who survive the cardiopulmonary event may have 2 to 5 day course of mild substantial respiratory insufficiency and complicated by pulmonary edema secondary to diminished left ventricular function. Prompted aggressive treatment during the initial phase is likely to decrease the reported maternal mortality, so you need to act actively. Hemorrhagic shock is characterized by failure of the circulatory system to maintain adequate perfusion of the vital organs. So shock organs are formatted. This insufficiency leads to a cellular dysfunction. Shock usually is life-threatening condition that requires immediate and intensive treatment. Correct management of patients in shock involves treating both the underlying cause of shock and the physiological abnormalities associated with the shock. The pathway of hemorrhagic shock is shown on this slide. The blood loss may lead to reduced circulating volume. Decreased cardiac preload, output, and decreased blood pressure also lead to decreased tissue perfusion and ischemia. These may lead to release of toxin and increased capillary permeability, multiple organ dysfunction, and decreased vasomotor activity. May also again lead to reduced circulating volume, and this is the vicious circle. Bleeding in early pregnancy, for example, in case of abortion, ectopic pregnancy, bleeding in late pregnancy or labor, in case of placenta previa or premature separation of the placenta, uterine rupture, bleeding after childbirth, for uterine atony, genital tract lacerations, retained products of the placenta, and different traumas, injury of the uterus or bowel during abortion, ruptured uterus, genital tract organs. You need to diagnose shock in the following symptoms and signs if they are present: fast and weak pulse, more than 110 beats per minute, low blood pressure, for example, systolic less than 90 milliliters per hydrogram, pallor, especially of the inner eyelids, palms or around the mouth, sweatiness or cold, clammy skin, rapid breathing, so breathing rate more than 30 breaths per minute, anxiety, confusion, or unconsciousness, and oliguria, less than 30 milliliters per hour. The management should be active. Urgently mobilize all necessary personnel. Monitor vital signs: pulse, blood pressure, respiration, temperature. These are called vital signs. If the woman is unconscious, turn her on side to minimize the risk of aspiration of if she vomits. Keep the woman warm, but do not overheat, and this will increase peripheral circulation and reduce blood supply to the vital centers. Elevate the legs to increase return of blood to the heart. If possible, raise the foot end of the bed. Start an IV infusion. Usually 2 lines are necessary, with large bore cannula or needles. Collect blood for estimation of hemoglobin, cross-matched, clotting factors. Uh, Rapidly infuse IV fluids, normal saline or ringer lactate. Initially 1 liter for 15-20 minutes. Give at least 2 liters of those fluids in the first hour. The aim is to replace 2 to 3 times the estimated fluid loss. Colloids have no benefit over the normal saline or ringer lactate. If a peripheral vein cannot be cannulated, perform a venesection. Continue to monitor vital signs, blood pressure, pulse, temperature, respiratory rate, and blood loss. Indwell the catheter into the bladder and monitor urine output. Of course, give oxygen by mask or nasal cannula. Take steps simultaneously to stop bleeding. For example, uterine tonic drugs, massage, bimanual compression, uterine balloon tamponade, aortic compression, and preparation for surgical intervention. Reassess the woman's response to fluids within 30 minutes to determine her condition is improving. And the signs of improvement are following: the stabilization of the pulse, you increase blood pressure more than 100 millimeters of interarterium, the mental status is improving, less anxiety, less confusion, and the uterine output becomes more than 30 milliliters per hour. If the woman's condition improves, adjust the rate of infusion of IV fluids to 1 liter in 6 hours and continue management of the underlying shock. If the woman's condition fails to improve or stabilize, provide further management. Coagulopathy, as I mentioned before, is both a cause and as a result of massive obstetric hemorrhage. It can be triggered by different obstetrical complications like abruptio placenta, fetal death in utero, eclampsia, amniotic fluid embolism. The clinical picture ranged from major hemorrhage with or without thrombotic complications to a clinically stable status that can be detected only by laboratory testing. In many cases of acute blood loss, the development of coagulopathy can be prevented if blood volume is restored promptly by infusing IV fluids, normal saline or ringer lactate. If fresh whole blood is not available, choose the following approach: fresh frozen plasma for replacement of the clotting factors, packed or sedimented red cells, cryoprecipitate to replace fibrinogen, and platelet concentrates if bleeding continues and the platelet count is less than 20,000. Usually 1 unit of red blood cells may increase hemoglobin by 10 gram per liter and hematocrit by 3%. 1 unit of fresh frozen plasma increased fibrinogen by 10-15 milligram per deciliter. Recombinant factors 7-8, NOVA7 or Coagil 7, 90 micrograms per kilogram body weight is recommended for the treatment of this hemorrhagic shock condition. The so-called deadly triad is a coagulopathy, hypothermia, and acidosis. All these conditions may lead to maternal death. Disseminated intravascular coagulation is another one life-threatening syndrome characterized by disseminated and uncontrolled activation of coagulation. This syndrome is associated with a high risk of macro and microvascular thrombosis and progressive consumption coagulopathy, which lead to increased bleeding of the patient. In critically ill patients with DIC, the 28 mortality rate is 20% to 50%, so quite high. Early diagnosis and appropriate treatment of DIC is of critical importance. DIC is acquired syndrome and characterized by dispersed or uncontrolled activation of whole blood coagulation, leading to intravascular fibrin formation. The signature feature of DIC is the loss of localized activation of coagulation and the inefficiency of normal coagulation inhibitors to downregulate thrombin generation. The risk factors for DIC, any of the obstetrical complication, like placental abruption, placenta previa, amniotic fluid embolism, intrauterine fetal death, eclampsia, and massive hemorrhage. During the DIC, excessive thrombin generation triggered by tissue factor and platelet activation takes place. Defective natural anticoagulant pathways, including tissue factors inhibitor, antithrombin, and protein C, insufficient fibrin degradation due to impaired fibrinolysis or exaggerated fibrin or fibrinogen degradation, and concomitant activation of the inflammatory process. Anyway, microvascular thrombosis in conjunction with hemodynamic and metabolic derangement contributes to multi-organ dysfunction. Signs of organ dysfunction include renal insufficiency, kidney insufficiency, respiratory failure, hypertension, and circulatory failure of impaired cerebral function. Clinical manifestation of DIC can be latent or compensated activation of coagulation. It may be overt DIC and may be latent or compensated DNC, which may progress to overt DIC or become a chronic condition. Types of DIC may be acute, typical in obstetrical practice, may be chronic DIC, which is characterized by subacute bleeding and diffuse thrombosis, and localized DIC, which is characterized by bleeding or thrombosis confined to a specific anatomic location. It has been associated with aorta aneurysms, giant hemangiomas, and hyperacute renal allograft rejection. No single diagnostic test exists for DIC detection. Usually, DIC suggested in the following combinations: clinical conditions like thrombocytopenia, prolonged prothrombin time, APTT, and absence of FDP or D-dimer. Other tests like CBC, protamine test, urinalysis also may help to exclude DIC. Perform a bilateral peripheral soft density chest radiograph if pulmonary injury is present. Based on the underlying pathological process as well as suspicion for areas of thrombosis and hemorrhage, for example, on ultrasonography. Treatment of acute DIC includes anticoagulants, blood components, and antifibrinolytics. The basis of DIC treatment is the removal of underlying causative factor. For example, uterine atony, abruptio of placenta. In most cases, the hallmark clinical indicator of DIC is overt bleeding, which may be related to consumption and coagulation factors. Ideally, an effective treatment for DIC would distinguish between hyperfibrinolytic and hypofibrinolytic fibrinolytic DIC and between overrun type and degradation type DIC. Antithrombin concentrates, the most important physiological inhibitors of coagulation. Recombinant human soluble thrombomodulin inactivates factor 8A and 5A. Protein C and APC concentrates exerts anti-inflammatory activity by inhibiting cytokine production, preventing neutrophil activation, and inhibiting leukocyte adhesion. Rapidly acting anticoagulant agent to increase the inhibition of the upregulated thrombin generation, for example, heparin or low molecular weight heparin, plasma and platelet substitution therapy. For women with coagulopathy associated with postpartum hemorrhage, the Scientific and Standardization Committee recommends monitoring of hemostasis throughout prothrombin time, APTT, close fibrinogen testing, and thromboelastometry. For ongoing postpartum hemorrhage with prolonged PT or APTT, the administration of fresh frozen plasma is recommended, particularly in the PT or APTT is greater than 1.5 times of the normal. For ongoing postpartum hemorrhage resistant to other treatment, tranexamic acid or activated F7 can be considered. The anticoagulant agents are used in the treatment of clinically evident intravascular thrombosis when the patient continues to bleed or clot 4-6 hours after the initiation of primary therapy. The anti-inflammatory properties of antithrombin 3 may be particularly useful in DIC secondary to sepsis. Heparin you can use on the basis of severity of DIC. Monitoring results of therapy is mandatory. Heparin augments antithrombin 3 activity and prevents conversion of fibrinogen to fibrin. It does not actively lyse but inhibits further thrombogenesis. It prevents reaccumulation of a clot after spontaneous fibrinolysis. Usually the dosage of heparin 80-100 units per kilogram subcutaneously every 4-6 hours or 20,000-30,000 units daily intravenously in continuous infusion. Antithrombin 3 is used for moderately severe to severe DIC. Alpha-2-globulin inactivates thrombin and other serine proteases of coagulation, including different factors of the coagulation, which may inhibit coagulation. The dosage of this preparation is depicted on the picture, usually 100 units per kilogram intravenously over 3 hours, and followed by continuous infusion of the 100 units per kilogram daily. The next preparation is recombinant human activated protein, C. This agent inhibits factor 5A and 8A in the coagulation cascade, so they may be used as inhibitors of the plasminogen antibody. The drug is named Xigris, recombinant from the human activated protein C. The dosage of this preparation usually 24 micrograms per kilogram. Aminocaproic acid also inhibits fibrinolysis via inhibition of the plasminogen activator substances to a lesser degree throughout antiplasmin activity. The main problem is that thrombi that form during treatment are not lysed, and clinical significance of the reducing bleeding is uncertain. So these inhibitors of the fibrinolysis are usually given intravenously. The complications of disseminated intravascular coagulation may result in acute renal failure, life-threatening thrombosis and hemorrhage in patients with moderately severe or severe DIC, cardiac tamponade, hemothorax, intracerebellar hematoma, gangrene and loss of digits, even death. Prognosis is influenced mostly by the underlying condition that led to DIC and the severity of the DIC itself. Thank you very much. It's all for this lecture, and I hope you have got the knowledge about obstetrical postpartum hemorrhage, and you can discuss it during your practical course and seminars. Have a nice day. Be healthy. Bye-bye.